Okay, so we're talking about healthcare. We just to remember the context. We're still this general social insurance framework, thinking about the costs and benefits of our social insurance programs. And we talked last time. We ended last time a discussion of sort of how can we apply the principles of Chapter 12 to think about what an optimal health insurance plan should look like. And we talked about essentially this trade-off between consumption smoothing and moral hazard, and talked about how it's hard to really justify a health insurance plan that doesn't impose some patient copayments, because for small copayments, there's not a lot of consumption smoothing loss, as long as you're not too poor, and there could be a large moral hazard gain. Now, however, there are exceptions. In particular, really, if people are very resource constrained, this could lead them to not use care that's beneficial. And even studies I review in the book show that even people who aren't that resource constrained do cut back on a lot of care that might be beneficial. And so that suggested sort of a more subtle approach of a system where the cost sharing imposed on patients should relate both on the resources and on the sort of value of the care, which is fine in theory. In practice, it's hard. But that's sort of what an optimal insurance program, health insurance program, might look like. Now, what's interesting is health insurance doesn't look like that. 15 years ago, health insurance actually was pretty much first dollar coverage. There's been a growth in deductibles. If you look at the figure from Chapter 15, you see the growth in the average deductibles for employer-sponsored insurance over time. There's been a large growth in the last 20 years in the deductibles people have to pay, which is sort of the most common form of coinsurance. So we have moved towards more patient cost sharing, but we haven't really done so in a discriminatory way of the kind that theory might suggest. And we're still in a world where, these deductibles are still relatively small for a higher income person. Even a $2,000 deductible, which is a lot for a lot of people, is still sort of pretty trivial for many, for higher income people. And the question is, why is insurance not even less generous? Why is it really, in some sense, a system which is sort of, in many ways, overly generous to a large part of the population? And the answer traditionally one answer has been the tax subsidy to employer-sponsored health insurance. Because remember, the way that health insurance works is if you're paid in wages, you pay taxes. If you're paid in health insurance, you don't. We talked last time about how that would lead people to be distorted towards getting their health insurance through their employer. But as another implication, which is it makes health insurance relatively cheap compared to other goods. So if I want to buy apples, I have to pay taxes first and then buy apples. If I want to buy health insurance, I don't have to pay through my employer. I don't have to pay taxes first. I just buy health insurance with pre-tax dollars. So it makes health insurance relatively cheap. As a result, people overconsume health insurance. The story I always tell is, I had a choice when my kids were little of buying the basic or comprehensive MIT dental plan. And basically, you could think of it as I could say, imagine MIT coming to me and say, look, would you rather earn $1,000 in salaries or $1,000 in dental benefits? Well, if the $1,000 in salary, that would basically, mean if I had another $1,000 salary, I take about $500 home. If I get another $1,000 in dental benefits, I get the whole $1,000. So I did it, and my daughter got these cool braces that changed colors, and they were awesome. Okay, because why the hell not? Okay, so basically, we think part of the use of the over-generosity of healthcare, of health insurance in America, is because of this tax subsidy. Now, so the tax subsidy, let's focus on the tax subsidy for a minute because it's an important policy tool. Basically, there's three fundamental things wrong with this unequal treatment of compensation in the form of wages and compensation in the form of health insurance. The first thing wrong is it costs a lot of money. So if we think that, look, either one's compensation, by treating one tax-free and taxing the other one, we lose $350 billion a year in revenues. The second is what I just described, which is it's potentially inefficient because it induces excessively generous health insurance. The third is that it's also inequitable. We haven't really talked a lot about equity in this class. We'll get there more soon. But the bottom line is, if you think about it, the way this works is you don't get taxed on the cost of your health insurance. That means the higher your tax rate, the bigger break you get. Well, what caused people to have a high tax rate? Being high income. So basically, higher income people get the larger tax break in this system. So if you think about it, what the tax subsidy is basically a bribe for employers to offer health insurance, and that bribe gets larger the richer the employee is. That's not really, doesn't sound very good as a policy design principle. So many people have said we should get rid of it. Indeed, one fun family story is I was coming back from the beach one day with my kids, and I got a call from a friend in the White House. This is in 2009 or 2008, 2009. Friend from the White House saying, the president wants you to come down, President Obama wants you to come down and talk to him about, the Affordable Care Act. And I was all excited. I hung up. I said to my kids, this is great. I'm going to talk to the president. My daughter, who was, I guess, 10, said, that's so cool. You're going to meet with him alone. I said, no, I'll be in a room with a bunch of other economists. And she said, oh, that's not that impressive then. So kids keep you humble. But I did get to meet with him with these other economists, and he said, well, how should we control healthcare costs in this bill? And the only thing we all agreed on for sure is get rid of the goddamn employer health insurance subsidy. That makes no sense, okay? The problem is that there's a political economy problem, which is that while I can talk till I'm blue in the face about how this is removing a tax subsidy, people say it's a new tax, okay, so that's hard to do. The other problem is that there's a political problem. There's also a potential economic problem, which is this part of the reason we have so much health insurance for employers, remember, is this tax break. If you take it away and employers stop offering health insurance, will people become uninsured? And that's a concern as well. So that's one reason people didn't want to take it away. Now, the answer to that is to have systems outside employers we can get health insurance, and I'll talk about that next lecture with the Affordable Care Act. But nonetheless, that was a concern, that basically if you got rid of this tax break, people would lose their employer-sponsored insurance, they'd become uninsured. For that reason, a much more popular idea is the idea of capping the tax exclusion. So let's say, instead of saying you're never taxed on your health insurance, let's say you're only taxed on health insurance that costs above the average level of health insurance. So if you buy a typical plan, it's tax-free. But if you buy a more generous plan, we're going to start to tax you. Okay? The idea there is, A, we raise money. B, then the tax break isn't encouraging excessively generous insurance. We're basically saying, look, we can't get rid of the tax break altogether. We want to make sure people get insurance. We're worried about them losing insurance, but we don't want to subsidize generous insurance. So let's have a tax break that's tied to sort of a typical cost of an insurance plan. Anything above that, you lose the tax break. It's called capping the employer tax exclusion. So that became a very popular idea. And I'll come back next time and talk about what happened when we tried to do that in the Affordable Care Act. But that's sort of one way people have thought about dealing with the economic fallout, the potential fallout of people losing health insurance, which say, we'll let you keep this tax break, but only up to a certain level. And that's sort of one idea people had. Okay? Questions about that? Okay, so that's all I want. Yeah, Enoch.
You mentioned higher income people will basically get more out of it.
Yeah.
I should be careful with how I phrase this. They get more money back because otherwise they'd be taxed more.
Yeah.
But more money means less to them than
less what?
More money doesn't mean as much to high income people.
Oh, well, no, but that's a great point. So you're saying as a percent of income, are they getting more back? The answer is a percent of income, so the very richest aren't, sort of the near rich are getting more. They're also more likely to have insurance coverage in the first place. But you're right, this comes something we discuss a lot in chapter 18, which is how do you measure fairness? It's very tricky. Okay? Yeah, Stephen.
We're still capturing information about, some people might just prefer to have more generous insurance, but that's fine because they could pay for it.
Yeah, exactly. The question is, why is the government subsidizing it? We're not saying you can't have it. We're just saying, why is the government paying for you to have it on the margin? The idea would be, if we go back to our flat of the curve, that we think giving people some insurance might be good for their health, but there's no reason why we should be subsidizing very generous insurance. Okay? Yeah. Okay.
Last class we talked about some of the benefits of the employer-based insurance.
Right.
Which was that it mitigates the adverse selection and spreads fixed costs. Is there a reason why it might be good to incentivize employer-based insurance?
That's one reason why. So in some sense, you could think of this as in economics, we talk a lot about what's called second best problems. The first best is 1401, like everything works. The second best is, well, if something goes wrong, what's the thing you can do given under those conditions, the constrained best optimum? You might make what's called a second best argument for the employer tax subsidy, saying, well, look, there's reasons why we want people to have insurance through their employer. The only way we can make that happen is through this sort of bribe to employers. So let's do it. It's like a subsidy to insurance. The problem, and you could say, and you might, the counter would be, well, if you're going to subsidize insurance, why do it through employers? And the argument would be, well, they're a natural pooling mechanism. And we'll come back next time to talk about why it might make more sense to use other pooling mechanisms. But that would be the kind of, this important kind of argument we need to get good at developing, which is recognizing that we're not in 1401. Given failures, what's the best thing to do and the trade-offs in those? Yeah? The medical effectiveness curve. Okay. Now, so that's what I want to say about the first, I said we talked about the benefits of insurance, the cost of insurance. But there's a whole other dimension now that we skipped in chapter 12 and 13 and 14, which is the role of the medical provider. When we talked about unemployment insurance, for example, the key thing that determined how long you stayed unemployed was your trade-off between leisure and UI benefits. But what determines how much medical care you use is mostly your doctor. I mean, you might decide whether you go to the doctor. When you get there, you're largely not going to not do what the doctor says. The doctor largely determining it. So now we have to ask ourselves, there's another component of moral hazard we have to worry about, which is moral hazard on the provider side, which is how do we think about not just what patients have to pay when they get health care, but how we should pay the providers to deliver that health care. Now, traditionally in America and the whole world, we had what was called a fee-for-service medical system. What is a fee-for-service medical system? What it sounds like. The doctor does a service and they get paid. Dr. Ahmet fixes my knee. Dr. Ahmet bills me for a knee. As long as the bill isn't insane, I pay it as the insurer. Okay, if Dr. Ahmet bills me $1 trillion fixing my knee, I know Dr. Ahmet's not on the level. But basically, as long as it's sort of, they had a thing they called usual and customary reimbursement, as long as it sort of sounds sensible. The problem with this is that this led to a concern of doctors overusing health care. So think about a doctor as having utility function. I'm not about malicious doctors, scumbag doctors. I'm not a regular Joe doctor, good guy. Okay? Regular Joe doctor's utility function includes two things. Your health as the patient and their income. They care about their income. They're not selfless. I said they're regular. They're not criminal, but they're not selfless either. Okay? As a result, think about the incentives facing that doctor to do any service which has even an infinitesimal chance of benefiting you, but might make them money. They'll do it. Okay? Indeed, you could go further and say if it doesn't hurt you too much, they might still do it. Measures which infinitesimally hurts you, but makes them money. They might still do it because they care about both things. As a result, as you think about that flat of the curve, doctor incentives are pushing way out towards the end of the curve. Because as long as it doesn't hurt you, and as long as there's even a chance it might benefit you. So let's say the doctor sees you, and you have something which once in the last 50 years someone found some of those conditions had brain cancer. So they order a brain scan for you. Okay, and finds nothing because it's one out of a gazillion cases it found something. But why not? Doesn't hurt you that much. Doesn't hurt you at all. It's just a brain scan. It makes them some money. So the concern with the fee-for-service system is it'll lead to overuse of healthcare, overprescribing healthcare by doctors. And that's why in the 1980s, we started moving away from the fee-for-service system towards managed care. A term you're all familiar with by now. Okay? Managed care is the notion of not just a purely system where doctors do what the hell they want and bill you for it. Okay? Managed care began in a very simple way with what was called preferred provider organizations. Preferred provider organizations, or PPOs. This is what started early on. The way these worked is they simply said, look, this wasn't really dealing with a moral hazard. This was sort of saying, look, there's all these extra rents being made by providers. And could we redistribute those rents back to insurers and people? And the way it worked was the following. It started out in California, Northern California. And an insurer went to Hewlett-Packard, or a company like Hewlett-Packard, and said, if I can save you 25% on your healthcare bill, would you be willing to tell your patients they can only use hospital X, Y, or Z? And Hewlett-Packard said, sure. Then they went to hospitals in the area and said, whoever will give us 40% off, you can get the Hewlett-Packard patients, but if you don't, you won't get them. The hospital's like, well, geez, we're making gazillions of profits. We're happy to give you 40% back to get the patients. The PPO pocketed the 15% difference, went back to Hewlett-Packard and said, hey, look, here's a list of hospitals. Restrict your employees to going to these hospitals, and you can save 25%. Essentially, they became a middleman, scooping up the rents that were being excessively earned by these healthcare providers. And PPOs lowered healthcare costs a lot, but not necessarily through changing the efficiency of healthcare. They weren't really addressing the moral hazard problem. They were just sort of scooping up the rents that providers at that point. Essentially, imperfect competition created rents. PPOs became a competitive mechanism to recapture those rents. Okay? So that was the first wave. But the really exciting wave was the wave of the HMO wave, health maintenance organizations. Because what HMOs were is they were essentially the integration of the delivery and the insurance of healthcare. HMOs said, let's get rid of the separation of the company that insures you and the company that delivers the care. Let's integrate them. And the most famous of which, initially, was Kaiser Permanente in California. What they did is they said, we are not going to have a system where your insurance, instead of signing for Blue Cross and Blue Cross pays whatever doctors want, you sign up for Kaiser. You have to go to a Kaiser hospital or doctor, so you get sort of the PPO effect. But moreover, we're going to change the way our providers are reimbursed. We're going to move from a fee-for-service system to a prospective reimbursement system. What is a prospective reimbursement system? A prospective reimbursement system is where doctors are paid not based on what they do to you, but based on something else. So for example, one type of prospective system is doctors just paid a salary. Kaiser just paid their doctors a salary. Didn't matter how many people you saw or what you did. So there's no more incentive to give the extra test because then you make you much more money. You made your X $100,000 a year, regardless of what you did to people. So we got rid of the incentive to overtreat people because your salary didn't depend on it. You can go further than that, so that's one approach. Further approach is the evil-sounding capitation, which is not decapitation, but capitation approach, which is to say to doctors, look, we're going to pay you you're going to have a panel of, it's the easiest thing with a primary care doc, pediatrician. We're going to say to the pediatricians, you're going to have a panel of kids. For every kid who's enrolled with you as their doc, you get X dollars. Stop. Full stop. Doesn't matter what you do to them, you get that. Think about this system. It flips all the incentives on their head. It used to be, when that kid came in my system, every test I did, I made more money. Now, every test I do, I lose money. Why? Because I get paid the same amount for the kid if I ignore him or treat him. So it flips the incentives on the head, and now instead of anything to undertreat. Because basically, what it does is it changes the risk. Who bears the risk? Under a fee-for-service system, the payer bears the risk. Under a capitation system, the provider bears the risk. Because they get a fixed payment regardless of what they do. So if they do more, they're going to lose money. If they do less, they make money. Yeah?
And that money loss is for the doctor because it's them spending their time doing extra thing?
No, because they literally...
Actually paying for it?
Well, but their time is money. That's why I use a pediatrician. I mean, I'm not talking about a surgeon. I'm talking about a pediatrician. Like, they get paid for their time. So now they're spending their time. So the point is, if a Met's a pediatrician, Val's a pediatrician, and the Met's going to spend 3 minutes, like my workers' comp doctor spends 3 minutes seeing kids all day, he can see a ton more kids than Valerie can. So he'll make more money. Okay? So basically, that was the switch, was basically the idea of kind of moving towards a prospective reimbursement system. This was a very radical change. Now, HMOs eventually evolved into two types. The original Kaiser type was what was called IPAs, independent practice organizations. Literally the full integration of an insurer and a doctor. But many people found that too restrictive. So we actually went to panel models of HMOs. The way the panel model worked is the HMO set up a panel of doctors. They didn't have to work for that company. So there's now I belong to the Blue Cross HMO. The doctors don't work for Blue Cross, but if you want a Blue Cross HMO, it's like a PPO. You have to sign up for it, and you agree, but it's a PPO with prospective system, with prospective reimbursement. So my doctor gets paid a fixed amount for having enrolled me by Blue Cross Blue Shield, but doesn't get paid anymore based on what he does to me. Okay? So IPAs are the most extreme form, where basically, literally, the insurer and the doctor are one and the same. The typical HMO is not that. Typical HMO is like Blue Cross, where the doctor's independent, but the doctor, to be signed up by Blue Cross, has to accept, I'll take this payment per patient. Or Blue Cross says, I won't sign you up. Okay? Because of this, and we'll come back to this next time, this is why the key differentiator across insurance companies is becoming their panel of doctors. Insurance companies don't differ that much, especially since the ACA, in what they cover. What they differ is in which doctors they've signed up. Okay? And obviously, the more money you pay doctors, the more you can sign up. Okay? So we've moved towards this prospective system. Now, what effect has this had? I'm moving to this. Okay? Well, on the one hand, the strong prediction would be it would save money. Because you move from one where the doctors make more money by doing more on the margin to one where the doctors make more money by doing less on the margin. The problem is you can't just compare those who are in HMOs to those who aren't, because it's endogenous. People get to choose. A sick person is not going to want to be in an HMO. They're going to want to be able to go to whatever doctor they want. HMOs limit your choice of doctor. It's only the doctor who signed up with them. So the problem is you have a natural bias problem in comparing those in HMOs and outside. There's been a bunch of papers that have dealt with this in various ways. Okay? They all come to a very consistent conclusion, which is A, there is enormous selection. Sicker people are much less likely to sign up for HMOs than healthier people are. B, when you control for that selection, HMOs save a lot of money. Like maybe 20%, 25%, a lot of money through this alternative model. Okay? So the first fact is the selection. The second fact is they're lowering spending. Yeah?
That save money is accrued just generally or to the actual person receiving it?
Great question. What is the, as we'll talk about in tax, what's the incidence of that savings? And basically, we think that a lot of it has gone to the insurers and some has gone to the people. In a perfectly competitive market, it would all go to the people. In fact, one test of lack of perfect competition in insurance markets is showing that when insurers save money, their profits go up. In a perfectly competitive market, they wouldn't. So we have an imperfect insurance market, and so they've been keeping a lot of it. Now, that raises the other question, which is, what about healthcare what about quality? Have they saved money by going too far? And the answer is no. The answer is that the quality of care overall delivered by these HMOs was no lower than it was delivered by traditional fee-for-service medicine. Now, there was a range. Some studies found it was lower, some studies found it was higher, but the consensus of the literature is basically zero. The consensus of the literature is these organizations are delivering comparable quality care, okay, at least in terms of patient health. Comparable quality care in terms of patient health at lower cost. Why? Because we're on the flat of the curve. Because doctors under fee-for-service were delivering excessive medical care. These HMOs managed to get rid of the excess without going too far. Now, there's a question, why didn't they go too far? Why doesn't a Met see a patient every 15 seconds and just make oodles of money? And the answer is because there seems to be enough incentives in our system pushing the other way that doctors still don't undertreat people. In particular, medical malpractice pressure, they might get sued, or just norms. Doctors still have patient utility in their patient health and their utility function. So bottom line is it feels like this move to managed care was a move which managed to move us in the right direction, not too far, if you measure by patient health outcomes. But there is another reason people like managed care, which is it's just a less pleasant experience. It used to be you go to whatever doctor you want and they just treated you. Now they have to review what procedure you're going to get. There's a bunch of extra paperwork. It's extra time. You might have to wait longer. So they've made the incidence in terms of who's won. Part of it is patients have lost because it's a less pleasant experience, but it's a lot cheaper. This is a little bit like, if you remember, those who took 1401 with me, remember I talked about airline deregulation, where everyone bitches about airline service, but no one bitches about the fact that the flights are a third less expensive than they used to be before we deregulated. because basically they were providing excessive quality. Doctors are providing excessive quality before. They're providing less, which is a little less pleasant, but we all like having the savings. Okay? So that is sort of the bottom line. Where does this leave us on optimal? So we talked about optimal design of insurance from the patient's perspective, which is about how you design cost sharing. What are optimal design of reimbursement? Where this leaves optimal design of reimbursement is that basically a pure fee-for-service system almost certainly makes no sense. The evidence is good that a managed care system may be a better approach, but there remains concerns in certain contexts of providers going too far. So you really want sort of a managed care system with some checks on it to make sure. So for example, something which may allow some escape valves so that providers don't, or just monitoring to make sure providers don't go excessively too far. Yeah.
For the airline example, the important part of that is that people are experiencing much lower flight rates now. Is that the case for insurance?
Much lower what?
Are people paying much less for insurance these days?
Yes. The price, well, it's just a time series, right? But certainly insurance is cheaper than it would be under the old system. Yeah. Yeah, this model is very much vertical integration. Well, that's a great question. This comes to we don't do antitrust in this class. You can take 1420, which is a terrific class to learn more about antitrust issues. But basically, that's the trade-off with antitrust in a healthcare setting, is that vertical integration can deliver efficiencies of this type, but it also lowers competition. And you'd think now it's an easy horizontal mergers are very bad for competition, obviously. Vertical are not obviously bad for competition because the insurer and the doctor weren't competing with each other. The question is whether you end up with these vertical institutions that self-refer and end up limiting competition. And so there's a rigorous debate about that. Okay? Yeah, Ina.
So we think quality hasn't changed that much, but the experience is much less enjoyable and there's a lot more procedures and paperwork people have to go through.
Right.
Does that kind of point towards not the purpose, because that's I guess out of this class, but is the point of health insurance such that you don't die, or just that your utility functions?
Well, that is a great question. I mean, in some sense, this comes to the very fact that economists think about health insurance differently than people do. Not that we're not people, but you know what I mean. Basically, economists think about health insurance the way I taught you in this class, which is it's a means of protecting you against risk. That is something which says that, for example, rich people should have high deductibles. People think about health insurance as medical prepayment. Think about it, I've already paid my premiums, I don't want to have to deal with anything else. Okay? Now, we can tell them in blue in the face they're wrong. That's not the point of insurance. But that's part of what people like. So, for example, people hate the idea of having to pay when they go to the doctor. And you can explain, well, actually, it's a small price to pay. It lowers your premium, whatever. No, they hate it. So if you really think of insurance as just something that makes sure you pay once every month and forget about it, then maybe people would rather pay more every month and have a hassle-free life later on. And the trick is, I'll come back to this later this lecture, do they really have that choice or not? And we'll come back to that. Yeah?
I understand the different ways of paying providers offer different incentives for the providers. What happens when one provider is paid by multiple payers?
It's a great question, very complicated and interesting question is, does it spill over? So if I treat, if half my patients are managed care and half are fee-for-service, does that affect how I treat the fee-for-service patients compared to all, and the evidence is not great on that. Okay, yeah?
Can I ask a question? So for fee-for-service, is incentive for the provider to be efficient and be more productive?
Right.
Even though you might be on the other side of the curve where the benefits to the patient may not be high. But I would imagine that with the managed care system, the incentive for...
No, there's no incentive to be more productive with fee-for-service. There's incentive to do more stuff.
Yep.
But that's not productivity.
In the sense if you look at a certain...
There's incentive to work harder.
Yep, to work harder.
Yeah, but working harder, it's an interesting point. It flips on its head what we learned about when we thought about labor supply. Talking about labor supply, we're like, look, you don't want to get in the way of people working hard. Well, the problem is people working hard in labor supply is increasing social welfare. People working hard here is lowering social welfare because they're living a bunch of care that, as Feldstein showed, has deadweight loss. So it's not productivity. It's a good distinction. Okay, so now that's sort of a lecture and a half on sort of basic healthcare economics. Now we're going to come for the next lecture and a half to the government programs and how we can take the tools we just learned and use them to think about optimal design of government health insurance programs. So let's start with Medicaid. Medicaid is insurance for the poor, Medicare insurance for the elderly, okay? So let's start with Medicaid insurance for the poor. Let me sort of now, like I did with the other social insurance programs, let's do 5 minutes on sort of institutions, and let's dive into the economics. So what is Medicaid? Medicaid is a federally subsidized but state-run program that provides health insurance to low-income individuals who reside in that state. Okay? Now, who is eligible? That has changed a lot over time. Traditionally, Medicaid began as a program for just those who were very poor, who were getting cash welfare checks from the state. So think people whose earnings were like $5,000 a year or less, like tiny, okay? Then during the 1980s and 1990s, it expanded for two groups, for children, especially children under 5, and for pregnant women. It expanded quite a lot to the point where in many states people were eligible instead of, if you weren't pregnant as a woman, you couldn't get Medicaid unless if your income was above $5,000. But if you were pregnant, you get it if your income was up to $50,000. So there was a huge expansion right up into the middle class, from the very poor into the middle class for those groups. Yeah. 5-0. So there's a huge expansion up into the middle class for those groups. And basically that happened, that kept going through the 1990s. And basically you had a situation by the year, into the 2000s, where basically any kid, anyone for pregnancy was eligible up to about the typical income in America. So basically, if you're below typical income in America, in most states, you're eligible for health insurance as a kid or for expensive pregnancy. But except for those groups, it was very hard to get. You had to be very, very poor. That changed with the Affordable Care Act. The Affordable Care Act made it a universal, what we call means-tested program, which is for everyone below 133% of the poverty line, which, as I said, for a family is probably about $30K or $32K a year. You now get Medicaid, not kid, adult, whatever. Okay. Now the kids still get it up to higher incomes. Kids still get it up to higher, but for everyone now they get it to 133% of poverty line. But because of a Supreme Court decision in 2012, states can decide if they want to offer this. And I'll come back to this next time, but for reasons that I will charitably characterize as political malpractice, a number of states have not taken up this option. So in about 10 to 12 states now, you still can't get Medicaid if you're poor, even if you're at 100% of the poverty line. Okay, yeah.
The money comes from the states?
From the feds. No, Medicaid in general is basically 67% Fed, 33% state. And the formula is an inverse function of state income. So basically, Massachusetts, 50-50. Arkansas, it's like 70-30. Okay, so the states, on average, the federal government pays about 56% of the cost of Medicaid. But these expansions under the ACA were 100% federal. State went to the states and said, we'll pay all the costs to expand. A number of states still said no. Okay, so that's who's eligible. What's covered, basically Medicaid is really good insurance. I like to call it the best insurance money can't buy. It covers pretty much everything, pretty much free. Okay, so basically any medical service is pretty much covered for free. In many states that includes dental, vision, etc., things that many health insurance plans don't cover. Okay, that's the good news. The bad news is that state Medicaid programs, they don't have a lot of choice over what they cover. They have a choice over two things. Who's covered, and as I said, the ACA is sort of taken a lot of that choice away, said pretty much you have to cover poor people, and how much providers get paid. And states vary a lot in how much providers get paid. And in particular, a number of states, providers get paid very, very poorly for seeing Medicaid patients. Typically on the order of, it can be as low as 10% of what they get for a privately insured patient. So for many, many years, doctors in New York, if they saw a Medicaid patient, I don't know what it is now, you got about like $12, where you're getting $200 for seeing a private patient. Okay, so basically, and this has been shown in survey after survey to cause doctors to not want to see Medicaid patients. And that's legal. It's illegal to turn someone away at the emergency room, but it's legal to turn someone away at the doctor's office. So as a result, on the one hand, Medicaid is great insurance, but you can't find doctors to take it, is the challenge. In particular, problems are particularly acute in rural areas and inner city areas. It's particularly acute finding doctors that will take the Medicaid coverage. So it's a mixed bag. Okay? That's Medicaid. Now, let's go back to the Chapter 12 framework. Okay? Moral hazard, we don't need to cover with Medicaid. Basically, it's got all the moral hazard-free health insurance would have, subject to the fact that if you can't see the doctor, there's no scope for moral hazard. Let's talk about, though, the other side, the benefits. So how do we think about the benefits of health insurance? Well, one benefit is the consumption smoothing benefit. Does having Medicaid help you smooth your consumption, in particular when you get ill? And the answer is strongly yes. There's a number of studies which show that when Medicaid expands and people get Medicaid, they are much less likely to go bankrupt. They're much more, the bankruptcy is mixed, but much less likely to have bad credit scores, much more likely to be able to have more to eat, much more likely to be financially stable and secure. So it looks like it is smoothing consumption of individuals. No, it does lower bankruptcy, that's right. Okay? So that's the one piece, and in some sense, that's the main piece, right? It is health insurance, but remember, the role of health insurance is to protect you financially. Okay, that's the goal of health insurance, protect you financially. And the answer is Medicaid does that job. People are not well self-insured against these medical risks. And when they get Medicaid, they're protected financially. However, really, truly, what most people seem to think is they want to know if health insurance is good for your health or not. That's what we sort of want to know with healthcare. And so the question then is, does having Medicaid actually improve your health? And it turns out this is kind of a complicated question. And so to do that, I developed this highly technical chart, which is the first chart we have, figure 16.1, which talks about the steps through which making someone eligible for Medicaid might actually lead to improved health. So let's say you imagine, let's take these ACA expansions. We increase eligibility for Medicaid. How does that translate to improved health? Well, it does through a number of steps. The first step is, well, you have to actually take that health insurance. So for someone who was previously uninsured to the right, you have to take up. Remember, we said take up is imperfect. Moreover, it may actually impact enrollment in insurance if you're already insured. Like I said, MIT makes me pay $6,000 a year for health insurance where I have a $3,000 deductible. Medicaid would pay nothing for a plan where everything's covered. I might think, gee, that's a pretty good deal. If I'm eligible for Medicaid, maybe I want to drop my private insurance and move over to Medicaid. That's a typical example of crowd out. We had a private insurance that's crowded out by this public insurance. And that can happen as well. So there's two ways that increased eligibility could lead to increased Medicaid coverage, through take-up of the uninsured and crowd out of the insured. Now, but coverage then, the question is, does that lead to increased utilization? And the answer is, it's not clear because of the doctor access problem. Coverage clearly will increase the demand for healthcare, but will increase the actual delivery of healthcare, depends on how supply constrained you are. So the next question is, well, if we get coverage, does it actually increase their utilization? Then the next question is, does that utilization actually translate to better health outcomes? We've talked about a lot of studies which are showing that changing health insurance doesn't seem to change health. We saw that with the RAND health insurance experiment. We saw that with these managed care example. So does it actually improve your health? And then the last step we care about as public finance economists is, does it do so cost effectively? Or should we just give people cash? Okay, this is a cost-effective way to improve health. Okay? So to study this, there's been a large literature, I've been a contributor to this literature, which has looked at the effect of Medicaid on various outcomes. And what we have is we have the huge advantage that the expansions in the 80s and 90s in Medicaid happened in a very differential way across states and across demographic groups. So for example, if you look at table 16.1, this shows what happened to eligibility for Medicaid among kids in 2 states. So in 1982, 12% of kids in Missouri were eligible for Medicaid. 20% of kids in Michigan were. Michigan is higher income and at higher eligibility. Why? Because their program was more generous in 1982. By 2000, when the states had expanded, now 76% of all kids in Missouri are eligible for Medicaid. That's what I meant. It really went up to the middle class. It's 34% in Michigan because Michigan's a richer state. So you have a difference in difference here, where because of a national expansion that increased it to a certain poverty, certain income level, that had a much bigger effect in Missouri, where people are poor, than it did in Michigan, where people are rich. Yeah. The CHIP program, I'm folding that into Medicaid. So basically, that is a classic diff and diff we can use to study. But it's better than that, because states expanded differentially for different ages of kids. So if you look at Missouri, in 1982, 18% of kids at age 13 were, I'm sorry, this is Washington, D.C., another example. In 1982, 18% of kids at age 13 were eligible and 48% were eligible at birth. By 2000, the share at birth had barely budged, but the share at age 18 had gone up a lot. So that's another difference you can exploit, is different age kids within a state. So it's got all the fun Chapter 3 stuff going on. Lots of differences floating around here. And so lots of people have used this. Now there's probably hundreds of articles written. And now, of course, we have a whole new literature because some states expanded under the ACA and some didn't. So we had an old literature, now we have a whole new literature that's using those experiments. So what have we learned? Okay. First of all, we've learned that take-up is very impartial. If you look at a straight line from Medicaid eligibility to Medicaid coverage, and you ask for every person made eligible, what share actually gained coverage? The answer is about 20 to 25%. Really low. To every person made eligible, only 20 to 25% get covered. But that ignores the fact there's two channels. Because it turns out most of the people made eligible by the expansion of the 80s and 90s already had health insurance. So what you really want to know is the two separate channels. How much is covering among people who are previously uninsured, and how much is crowd out? And what you find is that among people who are previously uninsured, the take-up is probably more like 2/3, which is kind of typical for a social insurance program. 2/3 is about how often people seem to take up these entitlements. By the way, it's crazy, right? This is a free entitlement, okay, that you're getting worth thousands and thousands of dollars, and a third of the people turn it down. We've talked about reasons why that might be information failures, hassle costs, stigma, etc. But nonetheless, it looks like it's about 2/3 take-up. Yeah?
Is there a reason why it can't just be given automatically to those who are?
Well, the question is, how would you give it automatically? It is given automatically. I mean, literally what you could do, I mean, you could send people letters, but the problem is the reason it can't be given automatically necessarily easily is because it's income targeted. So you have to first confirm my income. Now you can go back and confirm it with tax data, but that's old and takes a while to get, and the federal government doesn't like sharing tax data across branches. So this leads to a major issue we're having now in Medicaid, which is that during the crisis, during COVID, we essentially made everybody who applied eligible for Medicaid. We didn't check your income, basically. As long as you self-attested you were poor, we let you on. We didn't check if it was true. So the problem is now we're checking, and it turns out a huge, huge number of kids on Medicaid weren't actually eligible or aren't eligible now. And there's millions of kids losing their health insurance as a result, which is an issue we're dealing with now.
Is that like fraud?
Well, no, it's a great question. It's fraud if they lied about their income when they signed up. What about if their income has changed? Then it's not fraud. They ask about your income now. Now, technically, so the way Medicaid works is they do a reevaluation periodically, every 6 months or every year, where they re-ask about your income. So the idea is when you're made eligible, you're guaranteed to keep that eligibility even if your income goes up till the next recertification. At the next recertification, they ask you. The problem is the following. They do these recertifications. Tons of kids lose Medicaid. It turns out almost many of them, the best estimate is about 2/3, or half to 2/3, are actually still eligible. They just missed the letter, or they couldn't read the letter, or something like that. So this fascinating trade-off that no one's ever really figured out how to deal with, which is, on the one hand, I don't want to give rich kids Medicaid. On the other hand, when I try to kick people off, I kick a lot of people off who shouldn't be kicked off. And how do you resolve that trade-off? That's a really interesting problem we're dealing with right now, that many of the kids who are losing eligibility now may still be eligible. The parents just didn't get the letter, or they just can't read it, or they're not paying attention. Yeah.
Just like at the time of service, can you not just have the equivalent of that letter thing happening?
No, the problem is, how's the doctor going to know your income? I mean, the problem is, once again, that's universal would solve this, but without universal, it's hard to solve.
Is it fair to say that, like, I don't know, society is worse off if people have health insurance, for, let's say, during COVID, and then they get kicked off versus them not having it at all?
I don't think so. I don't know. I mean, you could talk about a model. Certainly, you could talk about a model where, like, you'd have to have a situation where, yeah, I mean, you could imagine you got health insurance, they found out they had cancer, and they kicked them off before they could deal with it, and they're sadder knowing they have cancer. Either way, their cancer wouldn't have been dealt with, but they're sadder knowing they have cancer. So it'd have to be something which involved people's sort of well-being of, like, knowing whether they're sick or not. That would be the story you'd have to tell. What about crowd out? Well, crowd out is real. I mean, crowd out, by the way, it's ambiguous whether crowd out be real or not, because remember, on the one hand, I described why I might want to drop IMIT insurance. On the other hand, if I drop IMIT insurance, and my income goes back up and I can't get Medicaid anymore, maybe I can't get my insurance back. And maybe I like my MIT insurance, I don't want to be in the government, et cetera. So it's ambiguous how big crowd out would be. The estimates here are varied, but the best estimates are crowd out and even how you define it. The best estimates are that of the people who get covered, about half came from previously uninsured and half came from previously insured. We call that a 50% crowd out. That of every person who's gaining, of every 1,000 people gaining coverage through Medicaid, about 500 used to have health insurance. And about 500 didn't have health insurance. Now, why do we care? Well, we care because the people who used to have health insurance now it's on the public bill, it used to be on the private bill. Distribution might be okay with that, but efficiency-wise, we're not really changing anything. We're just shifting costs from the private to the public sector. Classic crowd out issue. So that's the first node of this chart. The second note is, well, given that much of those people already had health insurance anyway, and given it's hard to find a doctor, do you actually get more health care? And the answer is unambiguously yes. Study after study shows large increase in Medicaid eligibility, in using health care when you get Medicaid. Despite the barriers, despite the crowd out, huge increase in health care utilization. Okay. Then the question is, well, does it improve health? Now here, it's a fascinating, I'm going to diverge for a minute to a fascinating sort of lecture on methods, if you will, in economics, because it's interesting, at least to me, and you got to listen. Okay? Well, you don't have to listen. I'd like you to listen. Okay. Basically, there was a literature up till about 2010, up about 2008, and that literature was fairly consistent that giving people Medicaid improved their health, that they used more health care and health outcomes were better. And there were all these sort of cool quasi-natural experiment studies, quasi-experimental studies showing, some by myself, showing that, for example, when mothers got Medicaid, the babies were much less likely to die. When kids got Medicaid, they were much less likely to be sick and go to the hospital. Lots of evidence that Medicaid was improving health, and actually that it was doing so cost effectively. That if you looked at the cost of increasing, we're spending on Medicaid versus what we're getting for health, we're doing like saving a baby's life for $1 million. Which if you think back to chapter 8 is not bad. I think lives are worth $10.5 million. Saving a baby's life for $1 million is not bad. So we're doing things, we're improving health and doing so fairly cost effectively. Okay, that was sort of round one. Round two was this very famous Oregon health insurance experiment. The Oregon health insurance experiment was a study where the state of Oregon decided they wanted to expand Medicaid. This is pre-ACA. Decided they want to expand Medicaid for adults. They wanted to add 10,000 more adults to their Medicaid program. So they took applications from uninsured people, and 100,000 people applied. So they decided a fair way to allocate it would be to have a lottery. So they ran an experiment. They ran a lottery, and 10,000 people got it, 90,000 people didn't. And a team that I was part of, but which was led by my colleague Amy Finkelstein and Kate Baker, formerly of Harvard, now the provost at Chicago, they looked at what effect this had using as an experiment. And the findings were people used a lot more health care. Like I said, that's clear. But their health wasn't measurably much better. Now, one exception, okay, their measures of physical health weren't better. Their blood pressure didn't change, things like that. One exception was mental health. Depression went down by 30%, almost instantly. So that's sort of weird because even Prozac doesn't work that quickly, and it wasn't like they're putting it in the water. What happened was, it comes back to what we were discussing a few minutes ago. It was our theory, the co-author's theory, is just the lack of stress of being uninsured. That facing constant financial risk is depressing. And that basically, by relaxing that risk on people, we improve their mental health. Which comes to these other questions about what is insurance for? Sort of contradicts a bit my earlier perspective. It doesn't really, actually no, it's contradicted. I would argue it doesn't. What it's saying is that's a measure of the benefit of insuring. The idea of insurance is to protect against financial risk. A measure of the value of that is how much better people's mental health was. Yeah. Adults. They didn't really survey. It was only expansion for adults. It was only expansion for adults. Side note on that, side note of a side note, talking about the way healthcare is viewed in America, this study was very famous, got coverage in the New York Times and stuff. When they wrote the articles, they said, study finds health insurance doesn't improve health. In the last sentence, they said, oh yeah, depression went down 30%. Which sort of talks about this sort of weak role mental health is in our society relative to physical health. And I think that's changing with your generation. There's a lot more attention to mental health than there was even 15 years ago when we did this study. But sort of an interesting side note about the value of people's view of the value of mental and physical health. Anyway, this is a real shot across the bow because people said, wow, we had this whole literature saying Medicaid improved health. What if it doesn't? Okay? Then we ran another experiment called the Affordable Care Act, where we had some people getting health insurance because their states expanded, others not. Okay? And what they did in those studies is they took massive samples of individuals so they could find really precisely what effect that had. And they found huge positive effects on health, much like the previous literature. Okay? From very convincing methods. Indeed, there was another randomized trial, which is really cool. Under the Affordable Care Act, we'll talk about next time, there was an individual mandate. That individual mandate said you had to report on your taxes whether you were insured, and if you weren't, you paid a penalty. Well, the IRS, after the first year, the IRS is our tax system, after the first year of this program, decided people who paid the mandate penalty, they should remind them, hey, get health insurance, you want us to pay the penalty. Someone convinced them, some brilliant person convinced them to randomly remind people. So they randomly randomized, and some people got a reminder letter and some didn't. I don't know how they got away with that, okay? What they found was the people who got the reminder letter were much more likely to sign up for health insurance, and their health improved. So here we have a situation where we have this sort of contradicts in the literature. I think the answer is pretty clear that the problem with the Oregon health insurance experiment is they only followed people for about a year and the samples were too small. Now, as a co-author, I'm not sure the lead authors would agree. I'm a junior co-author on that paper. I'm not sure they'd agree with my assessment of that. But that would be my assessment of of this debate. That basically we've pretty much sealed the deal. That that Medicaid coverage is good for your health, and that it probably improves your health cost effectively. But it is sort of an interesting study in how scientific consensus evolves. Okay? Questions about that? Yeah.
I remember when I was younger hearing about the Affordable Care Act and like some of the politics around it were such that like people hated the like.
Oh, come to the next lecture. We'll talk all about it. Believe me, I'll show you my scars. Okay? Okay, that's what I want to say about Medicaid. Now I want to turn to the other big program, Medicare, which is insurance for the elderly. All right, good. Remember, anytime I can sneak up on you and ask you this question. I have the right anytime to ask you this question. Okay, so how does Medicare work? Well, Medicare, unlike Medicaid, is a federal program, not a state program. Okay, it's a federal program. You pay, as I said, it's a program where if you've worked for at least 10 years, paying in your Medicare taxes, you then, when you turn 65, become eligible for the Medicare program. Or if you become disabled, after 2 years, you also become eligible for Medicare. So it's insurance for the elderly and the disabled. Elderly is a fine summary. I won't hit you with the disabled part. But for the elderly and disabled, people on disability insurance. Okay? Now, how does Medicare look? Medicare looks, traditional Medicare looks very much like old school fee-for-service medicine. Basically, you get the insurance, the government's your insurer, you go to any doctor you want, and the government pays the bills. Okay? And until the 1980s, that's basically how it worked. And we'll come back to what changed in a few minutes. Now, Medicare, however, is really 3 different programs. There's Part A, Part B, and Part D. I'll come back later to Part C. Why do we skip C? I'll come back to that. Part A is hospital care. That is what we pay for with our payroll tax. Our payroll tax goes in the Medicare Part A trust fund. That pays for your hospital care. Part B is doctor care. Doctor care you actually have to sign up for. So, and like 97% of elders do. But basically, it's a program where the government pays for your doctor care. That one, you don't pay any payroll tax, but you pay a premium that is 25% of the program costs. So that's more like the kind of insurance you have an employer. Okay, you pay a premium that's 25% of program costs. Okay, and that's Part B. Part D is coverage for drugs, and I'll talk about that separately in a little bit. Now, what this means is, while Medicaid may be the best insurance money can't buy, Medicare is actually not that generous. 20 years ago, it was much less generous than a typical employer plan. Now it's probably equivalent to a typical employer plan. This is shown in Table 16.2. This compares Medicare and Medicaid in terms of what you have to pay. Okay, first I have the eligibles. Talk about premiums. Okay, well, for Medicaid, there's none. For Medicare, you have to pay for physician coverage, and you also have to pay for prescription drug coverage. That's variable. We'll come back to that. Deductibles or copayments, nothing in Medicaid. In Medicare, you have to pay a $1,484 deductible. And then for hospitals, for physicians, there's a $200 deductible, and this is important, a 20% uncapped coinsurance. This is worse than any other insurance program. Every other insurance program you sign up for has a maximum. They say you have to pay out of pocket, but at some maximum will stop you. Medicare does not. If you spend $100,000 on doctors, you owe $20,000. Uncapped, and we'll come back to this. It's a real weak feature of Medicare. Uncapped coinsurance system. Okay? And Medicaid doesn't exclude anything. Medicare used to exclude prescription drugs. It used to exclude routine checkups. At least it wouldn't make it free. It excludes dental care, nursing home care, eyeglasses, hearing aids, etc. Okay? And then finally, reimbursement under Medicare is sort of between private insurance and Medicaid. If Medicaid is on average like less than half of private insurance, Medicare reimbursement's like on the order of about 70% of private insurance. Okay? So that's basically how the program works. Let's talk about prescription drugs. This is a fascinating debate, real-time, at least in my life, real-time debate. Okay, when Medicare was set up in 1965, it did not include drugs. That's because out-of-pocket drugs wasn't really a thing. It's like if you got drugs, you got them in the hospital, you took 2 aspirin and called them in the morning. Okay? It wasn't a thing. But by the late 1990s, the typical elder was spending more on prescription drugs than the whole program cost in 1965. Prescription drugs had become a big deal, and there's increasing awareness. This is a hole in the nature of the Medicare program. So basically, in George W. Bush's first term, there was consensus that something should be done about this. But there was a vigorous disagreement, goes back to Chapter 7, between the 2 parties on how it should be done. Democrats want to do this new drug program like we do the rest of Medicare, a single-payer fee-for-service system. Republicans said no. We should have a privately provided but federally paid system. We should have private insurers provide the prescription drug benefit, competing with each other, and the federal government will pay in the back end to those insurers. So it'll be like other insurance where the contractor is the federal government, but it'll be private insurers delivering it. And you see arguments on both sides. On the one side, the Republican argument makes a lot of sense. Competition works in many contexts. The idea is to have these competitive insurers, and they can innovate and things like that. On the other hand, innovation, what is innovation in insurance? Largely, it's innovation about how to keep out sick people, right? I mean, that's how insurers really innovate, is by trying to decide how to keep sick people out. So it's not quite clear why you want innovation. Now, I think the counterargument to that, which is valid, which is that, so the Republican counterargument is actually a lot of innovation is in negotiations with the drug companies. That basically is innovation how you decide to get the prices down on those drugs. To which The Democrats responded, well, the best way to get prices down is to have one giant payer who just screws the pharmaceutical companies, and that's what Medicare would do. Vigorous debate between these two things, and Republicans won. And we set up this program where basically people get their prescription drug benefit from a private insurer that's largely paid by the federal government. People pay a premium, which is a small fraction of the cost. The federal government pays the rest. Okay? So that's how it ended up. How did it do? Well, basically, it was much cheaper than we expected. The early evidence on Part D was quite good in terms of relative to what we thought the program would cost. These private insurance companies really got the cost down. Did they get them down more than the government could have negotiating? Not clear. And we'll come back to that next time, talk about the Inflation Reduction Act. But certainly it was less than we expected. They certainly did a good job negotiating these prices down. At the same time, we had the problem that people were confused by this array of choice and did not do a very good job choosing their plans. That's something I've done a lot of research on. We've shown that the typical senior, we looked at all seniors, we looked at the plans they had available and what they chose, and we sort of estimated what their cost would be under the alternative. And we found about 12% of seniors chose the lowest cost plan. And the typical senior could have saved on the order of $600 if they chose better. And basically, it's a very confusing choice. And basically, so the downside of the choice was seniors were not necessarily choosing the best plan for them. Yeah?
Would there be like a benefit to having the government sit sort of right on the end of that and say like, okay, you competed to create these different plans, and now here's a smaller menu of plans for seniors to choose?
We'll come back to that. Absolutely. Well, basically, could the government play with a choice architecture in a way that could have the best of both worlds? And we'll come back to that. Okay. What was most funky about Part D, okay, was the way they set up the cost sharing. Let me explain how it worked, okay? The numbers aren't quite precise and they're out of date, but here's how it worked, okay? So this is, on this axis, we have how much you spend on drugs. And this axis, we have your co-insurance rate. Okay, what percent of the cost of drugs you pay? Well, it was a $250 deductible. That meant for the first $250, you paid 100%. Okay? Then after $250, it fell to 25%. So at that point, you paid 25% of the cost of the drug, the insurer paid 75%. Until you got to, let me get the number, until you got to $2,500 of spending. At that point, it went back to you paying 100% until you got to $5,100 when it went down to 5%. Now, I hope you can see this does not make sense. It is hard to think of a Chapter 12 justification for a structure like this. Because remember, the whole idea is we're trying to combat moral hazard versus consumption smoothing. Well, these people, they're spending a lot on drugs. They need the consumption. It's not, why do these people need better consumption than these people? The moral hazard is probably less because you're taking expensive drugs, you probably really need them. And the consumption smoothing is probably higher because this is a lot of money to spend. So this is just clearly wrong-headed. Why'd they do it? Why did they set up the structure this way? A Chapter 9 answer. Give you a hint. It's a Chapter 9 answer for why they set up the structure this way. Yeah?
Most of the drugs are in that range where you have the highest co-payment and the pharmaceutical companies are not paying for that.
Most drugs are here or here?
Yeah, the one
Here.
Yeah.
Yeah, but the pharmaceutical companies get the same amount of money either way. It's just what people pay. So that's not quite it. What else? Yeah. The risk is here. The voters are here. So basically, or the voters are really here. In this flat part. So the idea was, instead of designing insurance to minimize risk, they designed insurance to maximize votes. Which is if they'd done the right thing, which said, look, we're going to have a 25% co-insurance to say $4,000, and then we'll get rid of it. All these voters would be like, no, I don't. Or if they said, we'll have a 30% co-insurance or something and then get rid of it. People are like, oh, no, I'm so upset. This way we're like, okay, for most voters, we'll keep them protected. These guys get screwed, but this is where there's where the risk is, but not many voters. So it's a classic political economy trade-off. Fortunately, the Affordable Care Act fixed this, changed this to 25%, and now there's now a cap at $2,000 where it goes to zero. So the new structure starting next year, the Affordable Care Act made this 25% to here. Okay, and now, you don't need to know this, just for, just for edification. Now the new structure is 25% till $2,000, and then you're capped. Okay? Yeah?
That latter change happened when?
That's part of the Inflation Reduction Act. Takes place in January. Okay? So that's an interesting, interesting political economy of how these things happen. Now, with Medicare, with Medicaid, I talked about the benefits and not the costs. With Medicare, I'm going to flip the tables. Yeah?
You said it takes place in January. The Inflation Reduction Act was passed, what, 2023?
2022, I think, yeah.
Why wait 2 years?
We always, that's a good question. I mean, you need to wait a little while because companies need to, that's a big change for insurers and how they structure the nature of their insurance. I don't know details, they have things like called formularies about which drugs are where. So you need to give them a little while. It's not, it's interesting. I'll talk about the Affordable Care Act and why the fundamental mistake was waiting so long. More time allows for better design, but it has costs as well. We'll come back to that. So with Medicaid, I talked about trying to measure the benefits and ignore the costs. With Medicare, let's ignore the benefits. It's good people have health insurance. Let's focus on the costs. Okay? The costs here are interesting because remember the first lecture I talked about CBO, the Congressional Budget Office, and now they're sort of the only thing keeping our democracy safe because they're the people who are sort of truth tellers in Washington. Well, it's a fascinating example that I like to use CBO. This Medicare was developed by Lyndon Johnson before CBO, and he basically kind of lied. He basically had his advisors say what Medicare would cost, and they were just way off. Now, were advisors just wrong-headed? I think probably not. I think they just understated it. But Medicare grew exponentially, okay? So basically, Medicare started out as, there was $64 million program in 1966. 14 years later, it was a $32 billion program, okay? It had gone from 64 million to 32 billion in 14 years and was growing exponentially. And Congress was like, wait a second, that didn't quite work out like we thought. We need to control costs. So Congress came up with two different approaches to controlling costs, which are fascinating to study. The first approach, once again, always I use the term fascinating loosely. My family makes fun of me for this, but once again, you have to listen. The first approach was to say, hey, let's move away from fee-for-service towards a prospective managed care, not managed care, but a prospective reimbursement system. In particular, they set up what's called the prospective payment system for hospitals. In 1980, this was very early, very innovative. How did the system work? The way it worked, they said, look, we're not just going to pay you whatever you bill. We're going to do the following thing. We're going to pay you based on how sick people are when they come to the hospital. Pay a fixed amount. So some comes in with this level of sickness, we'll pay you this much. This level of sickness will pay you this much, and then you do whatever the hell you want. We're not paying you anymore. So it's prospective reimbursement in hospitals. Instead of hospitals billing for every test, hospitals bill based on how sick the people are coming in. So what they did, now there are roughly 10,000 different diagnoses, and they didn't want to deal with a different price. So they set up what was called diagnosis-related groups, 457 DRGs. These are basically like, hysterectomy, not hysterectomy, depending on a woman's age or various things, or, broken arm, not like which part of the arm is broken, etc. Heart attack, there's 4 or 5 different ones for heart attack, where there's hundreds of different diagnoses for heart attack. So basically they said we're going to have a fixed amount we pay per DRG. So it's a true prospective reimbursement system. We're going to pay a fixed amount per DRG. Okay? Now, what if this is a great experiment? What effect did it have? You have basically something we're moving from retrospective to prospective reimbursement. But without all the other managed care features. This is just a pure reimbursement change. So it's not tangled up in all the things like independent practice organization stuff. It's the same doctors. You're just paying them different. So it's a great experiment. What did we find? What we found was more evidence for the flat of the curve. that basically what we found was there was an enormous reduction overnight in how the elderly were treated. So the average hospital stay for an elderly person fell from 10 days to 8 days within like 2 years. That's amazing, okay? Basically, we saw a huge drop in the intensity of hospital care with no evidence of adverse effects on elder outcomes. Classic flat of the curve, that these hospitals delivering excess care into the fee-for-service system. You move to prospective payment, they deliver less, but not so much less the patients are worse off, just enough less they don't quite make as much money. Okay? I did skip one thing that I want to come back to for 1 second, which is, what I didn't mention is, you could have asked me, you could have said, wait a second, John, I'm confused by something. The RAND health insurance experiment showed that the generosity of insurance didn't seem to matter for people's health. But you've just argued passionately that getting Medicaid matters for people's health. How is that consistent? And I would argue those two put together exactly illustrate the curve, which is getting people from having no coverage to some coverage. It matters for their health. But how generous that coverage is doesn't matter nearly as much. So that's sort of those two pieces put together are really what traces out this curve I keep coming back to. That it matters that you get some health care. It might not matter as much how generous that health care is. Just coming back to that before I forget. Now we're back on Medicare prospective payment. They put in prospective payment. It worked. Lowered healthcare costs, healthcare outcomes weren't any worse for a while. Then it stopped working. Hospital costs grew slowly for a while and then started growing again very rapidly. Because basically, hospitals figured out multiple different ways around this system. How would you get it? You guys are smart. Let's say you're running a profit maximizing hospital. I put in the DRG system. How would you get around it to get back to making more money? What could you do? Doctors aren't allowed to answer. What would you do? Come on, you guys are smart. I know you're not evil, but imagine you were. Yeah. You could change how people are diagnosed. If you look at the data, America's elders got incredibly sick overnight. Okay? There was a big jump in the diagnosis. Because you're paid based on diagnosis, they started diagnosing people as sicker. Now, you can't diagnose a broken arm as a heart attack. But you can diagnose someone who came with a broken arm and a heart attack. You can focus on the heart attack part, not the broken arm part. Okay, because the heart attack part gets paid more. This was, now this is just, there's the general, like, gee, we'll sort of on the margin code a little more complicated. And then there's the extreme examples. Like Cedars-Sinai in 1995, Cedars-Sinai Medical Center, Miami. Once again, it's always Florida. Okay, they coded, there were 2 DRGs. One for respiratory illness with a complex respiratory infection, and one with pneumonia with complications. So I have a respiratory illness, pneumonia respiratory illness. I can either call it pneumonia with complications, where I got paid $1,700, or respiratory illness with complex respiratory illness, for which I got $5,700. Well, at Jackson Memorial, which was a nonprofit hospital nearby, 28% of the cases were coded as the complex. In the for-profit Cedars Medical Center, 93% were coded as complex. Now, maybe they got a little more complex cases, but it's hard to imagine it was that different. And indeed, a number of hospitals actually were subject to huge lawsuits for clearly abusing the system. But to be fair, the system was designed to be abused. What do I mean by that? What I mean by that is literally any hospital is designed to be abused in the sense that it was partially retrospective. What do I mean by that? What I mean by that is, for example, if someone comes in with a heart attack, you could code them as cardiac arrest unexplained and get $5,000. Or you could do a coronary bypass, which is a different DRG. Heart attack with a coronary bypass got $33,000. Well, that sounds a lot like fee-for-service medicine to me. You do something, you get paid more. That's not prospective reimbursement anymore. So part of the problem was they didn't really commit to true prospective reimbursement. They said, well, gee, we'll actually pay some more if you do some of this stuff. So that was part of the problem, that it was still sort of a fee-for-service system. Okay? Another problem was it paid hospitals per admission. So what do? Well, you know, Paul comes in. Don't worry, Paul, you're not actually sick. I'm just using your name. Paul comes in. He looks shocked. Paul comes in, and we treat him, and we're like, Paul could use a couple more days. We're going to discharge him and readmit him and get paid twice. So hospitals started doing a lot of excessive discharge and readmission. Indeed, part of the Affordable Care Act I'll talk about next time was actually a policy to penalize hospitals for this excessive readmission. Okay? So that's another thing you could do. Another thing you could do is you could recognize that patients get treated in many locations, only some of which were reimbursed by PPS and some of which were still reimbursed fee for service. So for example, if you break your hip, you go to an acute care hospital to a rehab hospital. The acute care hospital, you get your surgery at the acute care hospital, they keep you for some amount of time, then they ship you off to the rehab hospital where you get rehabbed. The acute care hospital is reimbursed by PPS. The rehab hospital is still fee for service. So what they do is kick people real quick out of the acute care hospital, put them in rehab, and they paid. So they saved money. Our acute care hospitals went down, but our rehab hospital bills went up. So basically, hospitals became very good at figuring out ways to game this system. And it sort of talks about, what I talk about in the book is basically the difficulty of partial reform. It's like squeezing a pillow. Okay, you squeeze the middle, it comes out the sides. That basically it's very hard when you have underpaid, overworked government regulators and overpaid, underworked private executives. The private executives are going to win. And basically the trick is whenever you try to sort of play whack-a-mole, you're always going to be behind. It doesn't mean it's not worth doing. Even with all these changes, hospital costs still grew more slowly after PPS than they did before. Okay, it's just they slowed a lot, then sped back up, but never as fast as they were before. So you can't. The problem is people take these lessons as sort of nihilistic, like, oh my God, we shouldn't have done anything. That's not the answer. We were still controlling healthcare costs better with this system than we were before we had the system. It just had a number of flaws because of its. Now, so we've tried to deal with. So what do? We've whacked moles. We've put in a readmission penalty. I'll talk about that next time to try to lower costs. We've moved the whole system to PPS. So now you can't game the system by moving someone to rehab because the rehab's on PPS too. So we've taken steps to try to address some of these holes, but it's never going to be perfect. Yeah?
So with the heart example, does that like create an incentive for the hospital to get coronary bypass?
Well, certainly no more incentive than they had before because they always got paid more. It just didn't decrease the incentive. Basically, it used to be you'd bill more for it. Now you get a higher DRG for it. It's the same thing. So it didn't decrease incentive. Yeah? Oh, excellent, excellent question. So how do you do the empirical work here? Great question. Two ways. One is that PPS was phased in different parts. It was phased in over time. And the rate at which hospitals got phased in differed based on what their costs were initially. So you have sort of a diff and diff based on at what point hospitals were subject to PPS. It was over several years. You also have the fact that some states already had a system like PPS, so they were exempt from the PPS reform. So you have a state difference in difference. You can also do things like, if you look at, last thing, if you look at figure 16.2, what happened was, this is just a national change. It used to be that at long-term care hospitals, basically they would keep patients a long time. Okay, and they changed, and they were worried they were overpaying these hospitals. They put in a policy which said they were worried people were abusing long-term care hospitals when they didn't need to be there. So we're going to pay less for the first 29 days. Only once you've been there 30 days will we pay more. Look what happened. Afterwards, there was a huge increase in people staying 30 days because that's when the reimbursement went up. It's a national change, but it's pretty obvious something like that's going on. So you either look for sharp event studies like that, or you try to find control groups. Great question. Okay, let's stop there.